it shouldn't be as foreign to you, I don't think. But which one of you guys wants to tell me or talk to me about, just in general, what you're gonna think or see or feel or hear from a patient if they have primary lumbar pathology? What are they gonna talk about? What are they gonna say?
I got pain in sitting.
Okay, it hurts when I sit. What else might they say?
Maybe tingling down the leg.
Tingling down the leg, paresthesia, radiculopathy, okay? What else?
I got pain when I lift up objects or when I pick things off the floor.
Okay, fantastic. What else?
Bending and twisting.
Bending and twisting, okay, perfect. Now, all good. What might a patient say if they have primary hip pathology? And when I say primary hip pathology, let's pick the low-hanging fruit, OA of the hip, or femoroacetabular impingement syndrome, or a torn labrum, acetabular labrum in the hip. It could be muscular, just a severely tight or contracted, iliopsoas. What is a primary hip pathology patient going to say? And the most important part about that is, where is their pain going to be if it's truly hip pathology, typically? We're just talking generalities right now.
So with location, it's typically more in the anterior region.
The groin.
Closer to the groin, yeah.
Why? Well, so just think of your bony anatomy. So when people start talking and they say my hip hurts, a layperson who's not educated about anatomy thinks, oh, this is my hip. Well, not really. Look at where my hip is. Look at where my actual hip joint is. Look at where the actual joint is. So if it's primary hip pathology, it's going to be over here. If you got a patient saying my pain is here, it's probably not hip pathology. It could be, but it's probably not, right? Okay, so SI joint, okay? If a patient has primary SI joint dysfunction of some kind, I'm not going to say pathology necessarily with the SI joint, but dysfunction, malalignment. What are they going to say to you? What's their clinical cluster? What's their subjective history going to sound like?
It could be something like I have pain in my butt region.
I have a pain in my ass. Yeah, right. Okay, what else? That's supposed to be funny. It's okay.
Yeah, it is.
You can laugh. It's all right. Yeah, okay. Is it going to hurt when they sit? Yeah, typically. Why?
Because they're sitting on it.
They're loading it, right? And so if I have a patient that has SI joint dysfunction, oh, actually, this will be fun. So you guys are doing my eval, and I'm the patient, and I'm sitting like this, and I'm just sitting like this, and I'm sitting like this, and I'm sitting like this. What am I doing?
You're avoiding to load onto it.
I don't want to load over there.
Yeah.
Ow. But do we know yet if that's lumbar pathology, SI joint pathology, or hip pathology? Because right now I'm on my right ischial tuberosity. So if you think about a vector of force moving cranially through my ischial tuberosity, what's getting loaded? Okay, my bursa, my ischial bursa, sure. My SI joint, my lumbar spine. Is my hip joint getting loaded right now? My hip. My hip.
No.
Not really. Not substantially anyway. Okay? But my lumbar spine and my SI joint are, right? So if you ask the patient, hey, what happens if you shift over and you say, oh God, that hurts. Now I'm loading both of my ischial tuberosities, right? But what am I also loading? I'm loading both sides of my SI joint. I'm loading my entire lumbar spine. So do I know yet if this is lumbar or SI? And the reason I'm being so sort of rudimentary with this stuff is that you can be so methodically accurate about how to narrow down your differential to then direct your special test, your SI joint cluster, your hip exam, etc., before you even get the patient on the exam table, just by observing them and asking them certain questions. So right now I'm loading both SIs, right? Both ischial tuberosities, and my lumbar spine is getting loaded, but I'm not really loading my hips, right? Okay, so if the patient said to you, for example, Mom, this is cool, I'm fine here. Okay, cool, stand up. Ah, ow, now it hurts. What am I loading and what just happened? From here to here, what changed?
Now you load your hips.
Well, I'm loading all three now, right? Not directly like I am through the ischial tube. Okay, so you were fine in sitting. Did it hurt as you were getting up? No, it only hurts when I'm here. That's interesting. What structure are they now loading here that they were not loading here? There's only one. What is it? Well, no. Think about it. There's only one structure out of the hip, the SI joint, and the lumbar spine that right now it's not really loaded, because remember we decided this is SI joint load and this is lumbar spine load, but not such a hip load. And now I got hips, SI, and lumbar. They're all being loaded, right? I don't have a bar on my back with 225 pounds on it, but now I'm loading all three, and now I hurt. Well, where's the pain? It's kind of over here. What are you dealing with? Most likely, yes. Don't ever say, for sure, a hip. For sure, that's a tough one. Not until you examine, right? But these are the kinds of things that you do with your patient before you get them on the exam table. This is the discussion. This is the talk after they've given you the hellos. You know, this is why I came to PT. This is my doctor. They said you're the greatest. Oh my God, you're gonna fix me. You know, and they've got all these expectations, right? This is the conversation that you're having with them, you know, in the exam room before you put hands on them and before you ask them to do any special tests and before you're cranking on them. You're narrowing the funnel right now. That's what we're doing. Okay, so a couple of other of my favorites. You may not be able to do this in a chair, and if you can't, we move to the exam table. But right now, I'm loading both sides of my SI joint. I'm loading my whole lumbar spine. I'm not necessarily loading my hips, right? Okay, and I'm in pain. I'm in pain sitting here. Okay, so very gently, think about this. Let's say I'm 74, okay? Why might I be in pain in this position? I'm sitting upright, and we're trying to determine that the doc sent him with just LBP, which is garbage, you know, low back pain. Well, no shit, Sherlock, you know? Okay, I got low back pain sometimes too. All right, it doesn't really tell us much, but I'm sitting here, I'm 74, and I'm telling you, I'm in pain. Great, John. Can you tell me a little bit about that? Well, it's right above my waistline. It's right down here. Well, at that juncture, right above my waistline, and you guys can use kind of like, you know, PSIS to the a line across both iliac crests as like waistline, right? Okay. So just based on location of pain, it's not down in the sacral sulcus, it's not down near the coccygeal spine, it's literally between sort of a line that would level off your PSISs and a line that would join your iliac crest. It's waistline. What's the most likely in a 74-year-old patient named John, why they have that pain? Outside of a fall, outside of trauma, outside of tumor, outside of all the big, bad, and the uglies. This is mechanical diagnoses through conversation before we confirm on exam. That's what this is. Mechanical diagnoses through conversation, simple tests before we do an actual objective exam.
Probably
Shoot.
Arthropathy.
Arthropathy, yeah. What most likely? Outside of, you know, something sinister. I'm 74 and I'm active. I've been beating myself up.
Probably some like set syndrome or stenosis.
Perfect. Yes. Yeah. So, facet joint syndrome. Okay. By the way, we have a PT and a PTA here today. Both brand spanking new. Okay, and that's why we're going through this. That's the audience. Okay, so for you seasoned clinicians, you badass PTs out there, you're probably like, yeah, dude, tell me something I don't know already. Well, shut up. It's not for you. Okay, it's a brand new PT and a brand new PTA. Thank you very much. That was just my disclaimer. All right. So, waistline, right? 74, you said it. Facet joint syndrome, spondyloarthropathy, yeah. Facet joint arthrosis, right? Their facet joints, instead of looking like two sheets of glass like they did when they were your age, okay, now they're kind of crusty. They look like two heads of cauliflower trying to glide past one another. And it's not so comfortable. So, all right, John, how about if you just lean forward and put your elbows on your knees? And John says, oh my God, that's how I always have to sit because it feels so good. Now what are you thinking? Were you right? Yeah. Have some confidence. Yeah. Say yeah. Why? Because as soon as I flex forward, here I'm upright and I got pain right at my waistline here, not down here, because then we would suspect likely something else, okay? either localized to the SI joint, maybe the hip, or referred pain from the lumbar spine. But it's no, it's right here. And as soon as I put my elbows on my knees, it feels better. Okay, well, what am I doing? I'm opening up all of my facet joints, and because of the weight that I'm putting through my shoulder girdle via my elbow and my knee, I'm actually decompressing all of the lumbar structures because I'm giving the muscles a little bit of a break. Okay? Yeah, Marek hit the light switch with his big shoulder over there, that's all. So that is what's happening here. Okay? It tells you something, right? Okay, so next. Patient sitting, so where do you hurt? Like right back here in my butt. Hurts my butt. So I'm thinking, hey, 74-year-old guy, stenotic, spondyloarthropathy, facet joint arthrosis. Maybe he's got some exiting nerve root irritation. I don't know yet. I haven't examined him yet. I haven't done DTRs. I haven't done manual muscle tests. I haven't found myotomal weakness. I haven't found that his EHL and his anterior tib are weak unilaterally on the same side that he's complaining of pain. So I don't know yet about nerve root pathology or anything like that. I'm just having a conversation with a dude who's sitting in a chair with right ass pain. Okay? All right, cool. So John, if your butt hurts now, yeah, it does. Okay, so John, do me a favor. Shift your weight so that your right butt cheek, where it hurts, is hanging completely off the chair. Doesn't hurt anymore. What are you thinking now? So, right butt cheek on the chair, ow, hurts. Still sitting, but now my right butt cheek is hanging in airspace. Oh my God, you're a miracle worker, David. You cured me. My right butt doesn't hurt anymore.
I'm thinking SIJ dysfunction.
Okay, perfect, that's a possibility, but what else? Even something more simple. I'm sitting on my ischial tuberosity, ow. I float my ischial tuberosity off the chair. Feels good. These are so simple. And something right at the ischial bursa maybe. Maybe piriformis, okay? Maybe one of the 6 small external rotators at the hip that they were sitting on. We don't know yet because we haven't done our objective exam. But what I'm trying to do is to get you guys to just methodically think about what you can do with a patient really simply before you even get to your objective exam, so that it can direct your objective exam, okay? Instead of like, oh, please stand up, sit down, lie down, stand up, sit down, lie down. Shit, this guy's doing every test in the textbook on me. You don't have to. Talk to them and do some of these simple tests before you get them to the exam table. Because remember, your evaluation starts when you go get them in the lobby. That's when your evaluation starts. You never, ever, ever have an aide bring an eval back. You don't do that. You go get a new eval. Why? You want to see how they get up, for example, okay? Or you want to see how they get up, okay? Or you want to see how they get up. That is where your eval starts. Before you even speak to them, you're observing everything about them. And I always stand at the door and I observe them as they walk across the lobby to me. I'm evaluating them from the second they start moving from that chair. The moment, the instant, the second that they start, even their face. Hey, I noticed, John, when you were getting up from the chair out there in the lobby, you kind of grimaced a little bit. Did that hurt you when you were trying to stand up? Oh God, it's the worst thing in my life is trying to stand up out of a chair. Okay, what are you going to solve for? How are you going to be a badass PT for this man? The worst thing in the world, standing up from the chair. You now have your problem to solve. He already told you what his worst problem in the world was. Just because you noticed this when he went to get up out of the chair. But if you're not paying attention and you say, hey, Sean, one of the aides, can you go get John from the lobby? He's my eval. Don't ever do that. You're missing out on so much information just by watching how they get up to move, to come to you, and then stand there. Don't ever walk up, hey, how's it going? Don't do that. Hey, come on back, John. I'm Ryan, I'm your physical therapist. I'm gonna bring you back for your eval today. Why? Because you wanna watch this. You wanna watch that. They've been sitting there for 5-10 minutes, hopefully not that long, never longer than 5 minutes, but they've done their intake paperwork if they didn't already do it online and bring it in with them or email it into us. They've been sitting up there pissed off for 10 minutes of the clipboard filling out paperwork, thinking, this sucks, this is miserable, I shouldn't have come to this place, F these people, blah, blah, whatever they're thinking. Okay, this is where your eval starts. As soon as you call them out of the chair. When you get them in the exam room, LBP on the prescription. Thanks, doc. Doesn't tell us much, right? Okay, so John comes over to the exam table. You guys are sitting on the exam stool. If you want to grab another stool, Ryan, feel free. So I'm doing and practicing and kind of trying to outline what I'll generically teach you guys as binary PT. And by that I mean this. Come on, lights. There we go. Binary PT. So binary PT, it's just an expression. Binary PT, what is it? Binary PT just means, is it contractile tissue or is it non-contractile tissue? What's the contractile tissue that we deal with most? Come on, go. Yeah, muscle, right? Contractile tissue, muscle tissue or not muscle tissue? And then if it's not muscle tissue, what else is it going to be that's within the scope of our practice? It's going to be joint, it's going to be ligamentous, it's going to be tendinous maybe, it's going to be capsular, it's going to be bursal in nature, it's going to be neuro, okay? It's going to be some other structure that's non-contractile that a patient doesn't have volitional control over. If on these simple exam procedures that we determine it's contractile tissue, what must it be sensitive to for you to confidently, David, say that yes, 100%, I bet my license on it, their pathology is to do with contractile tissue, muscle. It has to be sensitive to
contraction,
yes,
stretch,
yes, and
palpation. Nice.
Yeah, contraction, stretch, palpation. Yeah. So if my biceps is paining me and you dig your finger in there, shit, man, that hurts, right? Okay. And if you put it on a big heavy stretch, I don't like it. And if you ask me to load it and contract it, I don't like it. Check, check, check. If it's only two of them, palpation and stretch, but hey, contractile effectiveness is really good. This guy can really produce power on manual muscle testing. I can put a 40-pound dumbbell in his arm and he can hold it isometrically. But as soon as I stretch him or as soon as I push and palpate, he doesn't like it. You're thinking maybe something a little bit different, right? Okay, so back to our simple exam procedure. Hip, SI, lumbar. What am I loading here? Just in general, lumbar, hips.
Lumbar.
Yeah, SI, lumbar, right? If I float my left ischial tuberosity off the table, now my ischial tube on my left is unloaded, my SI joint on my left is unloaded, and to a certain extent, my left lumbar facet joints compared to my right, because I'm leaning right, I'm side bent right, I'm loading really hard on my right ischial tuberosity and my right SI joint, and my right lumbar facet joints are loaded heavy compared to the left. I'm side bent in that direction and all my load and all my weight is over there. This feels fine. I don't hurt at all. Okay, cool. Now, oh, there's my pain, there's my pain, there's my pain. It's so simple, right? But now what do we need to do? I'm on my left ischial tube, I'm loading my left SI joint, and I'm loading my left, theoretically, lumbar facet joints heavier or harder than my right, because this is all hanging in space. And I'm side bent ipsilaterally to my left, the side that I'm sitting on. Okay, cool. So now, how do we unload SI and load lumbar? Or how do we unload lumbar and load SI? You'll have the SI joint cluster for Ryan. So your special tests for SI joint, what do you remember?
We have
compression, distraction,
sacral thrust,
Mm-hmm.
you have the thigh thrust, and then you have the last, then you have the gangsta.
Mm-hmm.
Yeah, so that's 5.
Perfect.
Typically, for it to be more likely to be an SIJ dysfunction, it has to have a pretty positive test on the 5.
Mm-hmm. Absolutely, positively. And subjectively, to help support your 3 out of 5 for your SI joint cluster, you want to have a subjective history that supports that objective finding. It's not always going to be perfect, but you got to listen to the patient. How did this come on? When did this come on? What's the severity? What's the intensity? The quality of the pain? Is it localized? Is it one side or both? Because if it's an SI joint, okay, versus the lumbar spine, is an yes, it's double high five. Yes. So if it's, yeah, you know, it's always right here. It's always right here. It's always right here. It's always right here. and it's below that waistline. It's like sacral sulcus. It's not here, it's here, okay? That's a typical guide toward leaning more toward SI joint. And then you're confident in the results of those tests on that cluster. Because, no man, it's on both sides and sometimes it shoots up my back. Is that really strongly supportive of your SI joint cluster? Yeah, not necessarily. But if it's always right here, always right here, always right here, no matter what I do, always right here, yeah, you can lean that direction, okay? So, and always from a patient is rare. Patients are not the best historians. I love them. I love all of them. But when we're trying to get our information out of them, sometimes it's way more difficult than it needs to be. And we have to be better detectives to make it easier for them. Okay, remember, they're our customer. If we were making a retail product, it would be, what do you need? How would you like it to be made? What color would you like it? What size would you like it to be? How much would you like to spend on it? And we would try to manufacture our product to be exactly what they want to spend their money on. But in a service business like physical therapy, we need to actually mirror the patient. What brought you in today? Please tell me your story. I'm here to help you. I'm going to be your guide. I'm going to do everything I can to narrow down exactly what your problem is today so that we can use a sniper rifle, not a shotgun, and nail this thing down once and for all, okay? With some manual therapy, which is hands-on care, some corrective exercise, some education, maybe some modalities like heat, ice, etc. if you're in a lot of discomfort or pain. But really what we do here is just, we're gonna try to optimize your motion and educate you on what's wrong. Okay, so I'm not gonna dial that all the way back to first year for a palpation exam, okay? But what we'll do is, talk to me about what landmarks you wanna palpate if you're examining a patient's lumbar spine SI joint in standing, okay? Patient is standing in front of you. This is Mr. Bones, or Miss Bones, Mrs. Bones, whatever, okay? What landmarks are you gonna palpate?
So typically with standing, just to get my bearings right, to see pelvic alignment, I'm gonna palpate right here at the iliac crest.
Okay. If they're level, doesn't tell you anything special, right?
No.
Okay, if they're not level,
Then I check out.
what might it tell you?
You might see either one iliac crest is higher than the other, or you can also reference the PSIS.
Mhm.
So they might be either anteriorly rotated or posteriorly rotated.
Okay, perfect. Ryan, anything else you want to palpate? You can also turn the patient around. What are you going to palpate on the front side?
ASIS.
ASIS, perfect. How about greater trochanters? Yeah, because if you do suspect SI joint pathology, maybe if there's an obliquity somewhere, okay, the trochanters are not exactly level, or if you give heavy pressure, one of them just doesn't feel quite right, okay? So would you do your compression and your distraction in standing, or would you do it in non-weight bearing?
It's
Perfect, you're right. Okay, so the one part that you guys didn't mention, okay, was the sacral sulcus itself, okay? And here's why I'm going to talk about this being important. So think about it. I know it's been a while since in school, but you know, we talk about nutation, counter nutation, okay, flexion, extension. Think back to your spinal coupling mechanics, okay? In extension, side bend rotation, coupled in opposite directions, okay, for maximum motion. Think of the sacrum like an L6. I know that sounds weird, but if you think of the sacrum like an L6, if a patient is in front of you and you've got your thumbs on the sacral sulcus and they feel equally superficial, okay, you're pushing, patient says, I feel good, I feel fine, that's cool, okay? And you don't feel this one closer to you, or you don't feel this one closer to you, or the other one deeper, they're equally superficial. Then you say, okay, to the patient, I'd like you to right side bend for me. And your thumbs are still here on the sacral sulcus. What should you feel in a perfect world if this is an L6? If I side bend right, my rotation is left. So theoretically, if the patient is standing in front of me and they side bend right, I'm going to feel my left thumb come toward my face. And I'm going to feel my right thumb move a little bit more anterior, because the sacrum is actually doing that about an oblique axis. The sacrum will rotate about an axis like that, or it will rotate about an axis like this. Now, my disclaimer, okay? This is all theoretical mechanics, right? And there's plenty of literature out there that refutes this, and there's plenty of people out there, clinicians, experts, etc., that say the SI joint doesn't move. You know, don't treat it. It's ridiculous, especially if it's a man, especially. I've been doing it 25 years. The SI joint definitely moves, and the SI joint definitely responds to treatment, okay? So you have to find, I know you guys are brand new, but you have to find a way to begin to trust your hands, the combination of your hands, objectively what you're able to measure, see, feel, touch, and what the patient is telling you. Otherwise, it's really hard to put all this stuff together with just theory. So, sacral sulcus palpation. Okay, we're going to do this on each other in a minute. Okay, sacral sulcus palpation. Side bend to the left. Call her Sally now. Okay, Sally Bones. Sally Bones, side bends to the left. What happens to my thumbs? My left sacral sulcus goes more anterior or deep. My right sacral sulcus becomes more posterior or superficial, because that is happening to the sacrum, to the SI joint. So really simple test, okay? It's just standing side bend while your thumbs are on the sacral sulcus. So you did great. You said iliac crest, you said PSIS, you said ASIS. Okay, we talked about greater trochanter. Let's add sacral sulcus, okay? So that we can actually assess, I'm not going to say prove, I'm not going to say disprove, I'm not going to say diagnose, assess movement and assess pattern and assess depth and assess tissue quality and assess response. So here's what will often happen if you've got a patient that has a pattern of SI joint pathology. You're going to ask them to side bend and they're going to go, oh, it hurts. Okay, where does it hurt? It hurts right here. Follow my logic. It's not up here. You've done your DTRs, 2+, bilaterally symmetrical at the knee and ankle. You've done your manual muscle tests, EHL, anterior tib, heel raises, all perfectly fine, normal. 5 of 5, 25 heel raises on both sides, no problem. Okay, but they try to side bend and oh, I got pain right there. Is it always on the right? Yes. If it's an SI joint pathology, right? Yeah, it's always on the right. Okay, cool. So I side bend right. What do I expect that sacrum to do if I side bend right? But they're telling me their pain is right here. My thumbs are here, okay? And when I palpated, before I asked them to move, I felt like my right thumb was closer to my face. And it was just a harder end feel immediately here. This I had to push through a lot of tissue before I felt like I was at bone, okay? So the sacrum, theoretically, before you even asked them to move, right sacral sulcus was more superficial, left sacral sulcus was more deep. Okay, following me? Okay, so that means that their sacrum could be stuck back on the right. Why on the right? Well, because when they side bend right, okay, their sacrum should be doing this, but if your thumb doesn't move and you're still on bone and it doesn't sink, and they tell you, bam, my pain is right there, you can have a reasonable assumption at this point, based on clinical history, based on, you've already ruled out lumbar spine, okay, through some simple tests, subjective and objective measures, and their pain is right here, and it's very constant, and it's there every time they try to right side bend, and your palpation tells you, dang, this thumb is really superficial and hard, and this thumb is really deep and soft, and their pain is right there, okay? So we're gonna say that they've got a sacral malalignment, okay, about a right oblique axis such that their right sacrum is stuck back, because that's exactly where the pain is, and your palpation and exam findings prove it. Prove. What else could we do, part of our SI joint cluster, what else could we do if we suspected that the SI joint was involved? Just really simple examination procedure to kind of give us a little bit more confidence that this is SI joint.
It's not the cluster test.
I'm trying to get you guys to think a little bit. If my SI joint, okay, and therefore my innominate likely is malaligned, what other joint motion might it affect? Hip what?
Like,
Hip internal rotation. Yeah, hip internal rotation. If you've got an SI joint obliquity or malalignment, your hip internal rotation is not going to be the same on that side. It's going to be less likely on the side of the SI joint malalignment than it's going to be on the non-affected side. General, okay? And in fact, what will likely happen, so we're assuming now that we know what the pathology is or the malalignment is. It's an SI joint problem. So to confirm that, simple part of a broader exam that we've been talking about, we're going to do an internal rotation exam of the hip. And their entire pelvis will often lever off the table because they can't independently rotate their femur inside of their acetabulum. So you're going to try to immediately rotate, and they're going to just come completely up off the table like this, which means there's not independent hip rotation. So now you've got another piece of information that you can reasonably add to your confidence interval that you're going to be okay to treat their SI joint and actually get somewhere with them, okay? So with this particular patient example, what are we trying to correct? We're trying to correct for right side bend without reproduction of pain here, okay? And your exam findings are as follows so far. Right-sided pain, always here, always unilateral. And based on what we talked about previously, gives you a little bit more confidence that it's SI joint, not lumbar spine. Because lumbar spine can be, and very frequently is, both sides, okay? Sometimes we'll refer to the buttock. We did our load, unload tests, etc. Still pain here, and very, very solidly feel that, man, this thumb hits hard end feel really, really soon. This one does not. Their pain is always here on right side bend. Okay, so I'm going to make some well-supported assumptions, okay? And I'm still going to say assumptions because for certain, we don't know until they respond, okay? Remember, a lot of what we do, okay, and I know that those of you that are publishing and those of you that are doing, peer-reviewed research are going to go, oh my God, I can't believe you said that. He's not a real PT. Yeah, cheers to you. A lot of what we do is going to be based on patient outcomes, okay? So if I've got a more superficial right sacral sulcus and I've got a patient with pain right here, okay, what can I do? What muscles can I recruit? How can I position my patient so that I can take this sacrum and bring it here, okay? How can I do that, okay? And you guys are looking at me like, oh my God, I hope he's not gonna ask me that question on camera. Oh my God. Okay, so I'll tell you the answer. Where does piriformis attach? Where does piriformis attach? Anterior sacrum, right? Okay, in general. And where does multifidi attach? Multifidi has multiple attachments, right? All over the place, okay? Multifidus is like one of my favorite muscles. That muscle is just badass. So, in general, multifidus is an ipsilateral side bender and a contralateral rotator. So my right multifidi will side bend me to the right, but it'll rotate me to the left. My left multifidi will side bend me to the left, but it'll rotate me to the right, okay? And we have attachments on the sacrum. So if I've got a right sacrum that I believe now, based on clinical history, based on lots of simple unload, load tests, and now palpation exam that corresponds with movement that I can justify with spinal mechanics and what I know about coupled and uncoupled motion, now I can go, I'm going to treat this patient's SI joint because I believe this patient has a sacrum on the right side that's stuck back. Cool. Nice. How are we going to do that? Okay. Okay. Do we use manipulation right away? In most cases. Not most cases, and certainly not at your first visit. That's actually kind of it's not a hard rule for me, but until I feel like I've got really great rapport established with the patient and trust, I'm not usually going to do a grade 5 HVLA technique on visit number 1 when we just met. I'm just, I mean, unless the patient actually says something to you like, David, just pop it, man. Just get on with it. Just pop this thing. I know I'll feel better. Just pop it. I want you to pop it. Okay, maybe in a case like that. Okay, maybe in a case like that. Do you know that Ryan's dad is a DO? And And his dad is like the master manipulator. Like we've worked on each other. He and his dad and me have worked on each other. And like, man, pow, 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 pow. Like your dad could walk into an exam room and just, it sounds like firecrackers with his patient. It's great. So unless a patient tells you or wants you to manipulate them, visit number one, hang back. I would just advise that from a rapport building, trust building, longevity perspective of practice. So anyway, right sacrum stuck back, okay? Which one of you is going to have a theoretical right sacrum stuck back that we can pull forward and left sacrum stuck forward that we can pull backward? Sure? Okay, yeah. Cool. Come on up here and lie down on your right side, please. So right sacrum stuck back, right here, facing us. All right, so what muscle attaches to anterior sacrum? We just talked about it. It's an external rotator. Come on, Ryan. Chop, chop, chop. Okay, cool. So this is, you guys call them, some of you guys call them muscle energy techniques. Some of you call them, what else do you call them?
We only call it METs.
METs, okay. I'm an old school guy. I've been at this 25 years. I don't ever say muscle energy technique because it sounds like I'm, wearing crystal shaka beads and I got incense in here and I'm going to do muscle energy over you and all this other stuff. I say, and you guys say whatever you want, but I say active mobilization. Active mobilization technique, because you're actively having to contract, and my goal, aim, target as a clinician is to mobilize you through your active recruitment of your muscles. So I say active mobilization. And funny story, years ago, like 20 years ago, I wrote a note to a physician and I said muscle energy technique in my note. And I got this phone call from this physician, and I will keep him anonymous, but yeah, hi John, this is Dr. So-and-so, and yeah, I sent you over patient so-and-so, and you mind telling me what the muscle energy technique is? Yeah, we can beep that out. And I was like, oh, I was a brand new clinician and I was totally freaked out. And ever since then I'm like, oh my God, what else can I call this? So I came up with active mobilization. So you guys call it whatever you want. Okay, so slide on over here, David, so you can see. So if Ryan has a right sacral sulcus that's more superficial, we're going to derotate you a little bit there. Hang on to the edge of the exam table. That always gives a patient comfort. And I've got his femurs stacked up, and I'm controlling his right femur with my knee, and I'm controlling the distal end via his foot, okay? You can see that I can laterally rotate his femur, and I can medially rotate his femur, okay? So if I want to recruit piriformis is a what rotator? External rotator. So if I want him to recruit his piriformis, I must impart a medial rotation force to his right hip so that he has to resist it trying to externally rotate. And in theory, because of where his piriformis attaches to the anterior right sacrum, when it pulls, it's going to pull that stuck back right sacrum forward. Okay? So don't let me move your right femur. Okay? Don't anticipate, just relax. You're already pushing the wrong direction, bub. Okay, I'm going to try to do this to you. There you go. And you should feel that where? Your right butt cheek, right? Yeah. So he's recruiting piriformis right now, externally rotating. Rest. Good. Really fires it up, doesn't it?
Yeah.
Okay. And you can kind of in your mind's eye imagine piriformis pulling on the anterior right sacrum. Okay? Hold. Again. Good, Ryan. Good, 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 good. Excellent. And relax. And depending on patient tolerance, depending on patient age, depending on contractile ability or inability, hold. You're going to decide how many bouts of this you'll do. For today's demonstration, we'll do 3 bouts. Okay. Rest. And then we're going to bring him back. Okay. Now, remember, right sacrum stuck back, left sacrum stuck forward. I want to also, to really, really tie this with a nice red bow, pull left sacrum backward. Okay? So how am I going to do that? Remember my favorite muscle, multifidus? Mm-hmm. So I'm going to bring you into sideline, and I'm going to come all the way down through palpation, down to the lumbosacral junction, and I'm going to flex him right up. Okay, Ryan, straighten out your bottom leg, please, for me on the table. Good. So, David, follow my logic here, okay? I'm going to rotate him all the way down all the way down through the lumbar spine, down until I can feel sacral segments starting to move. Lumbosacral segments starting to rotate. Okay, Ryan, in this position, don't let me rotate you any further. There you go. So he is doing what direction rotation? He's trying to rotate his torso. What direction? To his, no, come over and look. To his what?
Right.
So, right. Okay, rest. So if you look at me, I'm literally trying to split them. Okay, rest. I'm literally trying to split them apart like this and rotate him further and further to the left.
Oh, yeah, the top right. So
And I'm asking him, now, resist me, Ryan. Okay, you're going to break my arm. Okay.
Sorry.
No, it's okay. You're strong. Now he's rotating to his right, recruiting left multifidus. That's pulling on his posterior sacral elements. So we used right piriformis to pull right sacrum forward. We're using a left multifidus to pull left sacrum backward. Okay, rest. Good. And then just like we would with any other pelvic techniques, go ahead and come over to your back. We're going to try to use his adductors to put, I got it, I won't step on it, to pull his pelvic girdle apart at the pubic symphysis and let it rebalance to center. Okay, so bring your knees apart for me, buddy. Okay, squeeze as hard as you can toward the center. Boom, come on. You squeezing? Rest, good. Any pain back there?
No.
Okay, one more time. Excellent, rest. Good. Okay, come on up to sitting for us. And then the million-dollar question that all of us want to know is, how or what do you give a patient to do at home? How in the world does he recruit his right piriformis and his left multifidus, right? So that he can take his sacrum and do this with it, okay? So if I wanted you to recruit your right piriformis like we did on the exam table, okay? I'll mirror you so that you can do the same thing. Okay, cross over this way. I'm going to try to pull my right knee up toward my left shoulder. You're not going to let that happen though. So straighten your arms out here. Okay, you're going to recruit your piriformis. You're going to externally rotate that hip. You're trying to pull this knee that direction, but you're going to resist with that muscle right there. And you feel your right butt cheek come on just like you did when I was doing it. So here's his right piriformis recruitment. Okay, good. And Ryan, when I had you in side lying, what direction were you trying to rotate? Toward your right. Okay, so all they need is a door. Okay, that's my right, yes? So I've got my heel on one side, my shoulder on the other side. And I'm gonna try to break the door. And come on over here, David, and you can palpate multifidi down low near my sacrum or my lumbosacral junction, wherever you want to go. Yeah. Okay, ready?
Yeah. No. Yeah.
And all I'm trying to do is rotate in that direction and break the door. You feel how strongly that comes on? Okay, and that's all I'm trying to do. So the patient doesn't need any equipment at all. These are all very simple. And for the isometric adduction contraction, they can use a basketball, they can use friends and family, you know, they can use, you know, a pillow, a couple pillows, etc. I would always reassess your palpation exam. Again, did anything change? But most importantly, and this is where a lot of the literature might be divergent. For me, as a clinician slash business owner slash servant of my patients, I don't care if this is not perfectly supported in literature anywhere. I just don't. What I care about most is, can my patient go, oh my God, that doesn't hurt anymore. That pain in my ass is gone, right? I can bend this way and it's not there anymore, okay? All right, that is good, solid, mechanical physical therapy, history taking, subjective exam, objective exam, rule in, rule out, palpation exam, put the pieces together, and actually see a change in your patient's movement pattern, okay? And that has a lot to do with what we do in outpatient physical therapy. That, putting it together from start to finish, okay? Simple example, you know, hopefully it wasn't too silly for you guys.
No, that was real.
Okay. Lastly, and this is again around that concept of binary PT, What structure is it? Is it a joint? Is it a muscle? Is it back? Is it hip? Is it SI? I don't know. Ryan, go ahead and stand up and face the wall there. So, David, if Ryan is flexing forward at the waist, think about all the things that are moving, right? His lumbar spine is moving. His innominates are moving on fixed femurs. His SI joint is nutating, counter-nutating as he flexes and extends, etc. So how in God's name do we know, which of these structures is actually his pain generator? Or if he's side bending, okay? Lumbar spine's moving. His hips completely shifted over, so we know that there's some motion here. Same thing. His hips shifted over. His lumbar spine moved. There's a lot of movement happening, right? Or if we extend him, okay? We need to do some abdominal strength training, young man. Okay, back up toward me. Let's say that forward flexion bothers him, okay? Come on up. Where did that hurt? And let's just, for argument's sake, where did that hurt? Tell me where it hurt.
Right back here.
Okay, perfect. So, what moved? His lumbar spine moved and his innominates moved on a fixed femur, right? Okay, Ryan, can you just do this for me now? And you might have to give your patient some support, it's fine. So now, his hip is moving, his SI joint is moving, and maybe if he comes up really high, his lumbar spine will move. But if he does that, and he tells you, my pain's still there, is it his lumbar spine? Is that most high on your list? If this hurts, yeah, that hurts too, but he stayed tall and he didn't move his lumbar spine much at all. Does lumbar spine move down on your differential list at all? Or is it, this is how I want you guys to start to think, okay, in pieces. Let me help you with that. So let's say I take him in here and I come across his pelvis and I compress him really tight, really hard, okay? Feel how hard that is? Now flex forward and go ahead and bend forward and come on up. And if he says, oh, now it doesn't hurt. Well, so his lumbar spine, when everything moved, oh, it hurts. But when you took his pelvic girdle and you really wrapped him up and you kept it tight, go ahead and bend forward and his lumbar spine still moved, right? Yeah. Come on up. But now there's not so much movement of his innominates, his pelvic girdle on femurs, and man, that's better. So think, everything's moving, hurts. Now these couple of parts don't move as much better.
Oh, yeah, I'm thinking.
You're not thinking lumbar spine anymore. Yeah, you're thinking, hey, I stabilized something and now his pain went away. That's interesting. Maybe it's not his back. Ryan, could you try that one more time, please? Bend forward. Ow, 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 ow. That hurts. Okay. Come in here, shoulder, coracoid right against his trochanter. You grab the opposite. You really compress his SI joint and you don't allow him to move much, and he's much, much better. Now you're thinking, hey, I'm going to leave lumbar spine alone. I'm going to focus a little bit more on pelvic girdle, SI joint.
Yeah, because once you apply that form closure, it narrows it down more to like anything.
And this is how I want you guys to keep things simple. Like there's so much awesome stuff out there. Special tests, manual muscle tests, fantastic functional exercises, et cetera, but actually being in an exam room with a patient who's got some sort of an esoteric pain that either is or is not mechanical requires us to be really, really good biomechanists. What's moving? What's not moving? What can I immobilize? What can I mobilize? How can I reassess right now so that I can narrow down this list of what it might be and just focus on the thing that I believe it is most likely to be based on my clinical exam, okay? Another thing for you, David, if your patient's standing here in eval and they're saying, it hurts here. Well, okay, it could be referred lumbar spine, it could be SI joint, it could be trochanteric bursitis, it could be all sorts of things, right? But what can we do? We can compress, we can take ASIS, and we can take posterior aspect of his ischial tuberosity, and we can literally lift up his innominate. So let's say every time Ryan does this, that's when this pain hits. He side bends to the right, bam. Think about all the structures he's loading. right lumbar spine. SIJ is having to move anteriorly on the right, posteriorly on the left, based on our mechanics. His hip is getting loaded a little bit more. Okay, so you know what? Let's do this. Let's take his SI joint, let's take his innominate, and let's pick it up, theoretically, but I mean, I'm really picking it up, and Ryan, you can tell him how much I'm unloading you. Like, I'm taking his innominate off of his femur. Now do the same right side bend, Ryan, and now come back up. Do it again, and come back up. And if that alleviated his pain or his symptoms, just that simple, I'm gonna unweight your hip a little bit by taking your innominate up, and I'm gonna ask you to do the same painful motion, and now it's not as painful, and it's substantially different. You gotta think, what did I do? What's different? Oh my God, I unloaded his hip joint a little bit. His femur was still in the same spot. Everything was still moving in the same direction, but his symptoms were very different. I even loaded his lumbar spine. You could think doing that to an innominate is loading lumbar spine even more. Whoa, but his pain was so different. I unloaded his hip. I think I'm gonna focus down a little bit more on this hip joint before I decide what this is and how I'm gonna treat him. So your exams are very rarely gonna be exactly like they taught you in school. They're very rarely gonna be.
Because right there, you're kind of using the, the SIJ to like kind of be that bridge to see like, is it really the lumbar spine or the hip, or if that none of that works. I'm assuming it's more the SIJ. So it's kind of like using those three to weed out which one it really is, like using those.
Correct.
Joints,
And these are the kinds of exams that I want you guys to get used to. You're both starting your careers. Do not, I love this term, but it's crass, so forgive me. Don't get shit canned into doing it exactly, one way. Listen to your patient. And if it's not smelling right, not sniffing right, don't grab onto something because the referral says shoulder pain. Well, okay, but what if it's cervicothoracic pathology? What if it's a facet joint syndrome in the C-spine that's referring pain into the shoulder girdle, and their primary care physician did not have any idea how to look at that or diagnose that, and doesn't even know what a Sperling's test is, right? To load up a cervical facet joint and reproduce scapular pain, but they said shoulder pain, and you're gonna just glom on to the idea that, oh, this patient has weak external rotation, so let's go out and do some shoulder girdle strength training. No, they need cervical traction, and they need some facet joint mobilization, and they need some postural re-education, and their scapular pain disappears. But if you're just banging away on the rotator cuff because you just grabbed onto what was close, and you didn't really take your time to narrow that funnel and to listen and to test and reassess and to test and to reassess, you're gonna miss a lot. So take your time, keep it simple, and use very simple mechanical techniques to help guide what special tests you're going to do, and more importantly, what treatment you're going to do when you get to the clinic, because that is actually what will tell you right now, is this patient better or is this patient worse? Is this patient better or is this patient worse? Is this contractile tissue? Is this non-contractile tissue? Is this even within the scope of my practice based on what this patient is presenting with right now? So slow it down and don't be so caught up in making the exact right call. Have fun being a detective. Have fun doing these tests, mechanical tests, coupled with the patient's subjective history, so that when you do start treating, it feels like you've got a sniper rifle with a scope, and you're trained right on your target instead of using a buckshot from a shotgun. I'm just gonna treat everything because I don't know what the hell it is. Like that's just not a good route to go. So slow down, take your time. And really, these kinds of exams, one of the things that I've noticed over 25 years of practice is patients love them because it makes sense to them. It's so simple. And they're like, oh my God, I see what you did there. Whoa, yeah, you're right. Hey, when I do this, it doesn't hurt. But when I sit with both of my butt cheeks on the chair and I do this, it hurts. Wait a second. So, whoa, so what does that mean? And then you get to tell them, boom, here's what that means. It's very cool. And it's easy, and it's simple, and it's actually fast. And if you get used to doing them first visit, second visit, you actually will completely collapse time for your patients and get them better faster, because you really narrowed your funnel at the beginning of their treatment course. All right? Questions? I know I talked your heads off today, but I wanted to deliver as much value in as short amount of time as I possibly could. That's what I do with patients.
I guess with the SIJ unloading, where were your hands specifically?
Sure.
Yeah.
So right up here in his ASIS,
Okay.
and right at his ischial tube,
Oh, okay,
and
ischial.
boom.
Okay.
So Ryan, hold Mr. Bones here. Bam, bam. Here. You can come here. It's just a little harder. Okay. And if it's a small, he's a thick dude. So there's a lot of tissue to push through down here.
Yeah.
So this is actually easier.
Okay.
But if it's a very slight person and you can go right to the ischial tube, boom, it's easy. Okay? But you're just unloading the hip. Okay?
Yeah.
And you may want to try the compression of his whole pelvic girdle, like I did when we were doing the flexion extension of the lumbar spine, so you can give him feedback on how hard I was actually trying to stabilize you. And you're gonna really get in there and lift. And then wrap around and see if you can stabilize his pelvic girdle. And Ryan, give him feedback on how hard he needs to pull to actually stabilize your pelvis based on how hard I was pulling you into me. And this is when you are gonna go flex and extend. You're gonna have to drop this arm down a little bit. There you go. And so when you're flexing and extending, tell him about how much pressure.
Oh, even more? Okay. Yeah.
I'll do it on you too so you can see.
It was quick, pressure.
So if you stand up, David, and flex and extend, for example, just flex and extend through mid-range, okay? So now you've got lumbar spine moving, you've got innominate moving, you've got a fixed femur, and I want to know, is there a pain generator to do with your pelvic girdle, not with your lumbar spine? I'm going to do everything I can to come in here and say, all right, David, I'm going to do my best to immobilize your pelvic girdle while you do that lumbar movement. Go right ahead.
Oh, wow. I really do feel unloaded down there. Yeah.
You feel the difference?
Yeah.
Okay. So
makes you feel like slightly way less.
Yeah.
Feel almost way
I'm not lifting you. I'm just totally compressing your pelvis so that I'm gonna theoretically, right? I'm sure it's still moving a little bit, but it's moving a lot less. And now, oh my God, wow, John, that doesn't hurt at all. You can confidently say to yourself, if I had a big, ugly, nasty, herniated disc, that's still gonna hurt like hell.
Yeah.
No matter what I'm doing to your pelvis, you know, it's still gonna give me my radicular pain or my radiculopathy, etc. But now, hey, the pelvis is compressed and immobilized and that doesn't hurt at all. Back, probably clear. Because what was moving and causing pain is now no longer moving because of you causing pain. And now you can drill down. And now you can confidently leave the lumbar spine alone and train your sights and your focus a little bit more on the pelvic exam and the SI joint exam or the hip exam, depending on patient's history, special tests, etc. So these are all super, super simple, right? Questions? We can go through the same type of stuff at the shoulder girdle, elbow, neck, like you name it. We can do these binary PT mechanical exams. It's just about every body part. But it really helps you in an exam room to just go boom, 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 boom. Oh, that's what it is. And it's really simple. Okay? All right, thank you very much.
Thank you. Yeah, that was awesome.
Okay,
Thanks, John.
cool beans. Yeah.
Appreciate it.
That's along the lines of what we do in our residency. So, you know, with the literature to back it up and the reading assignments and the practicals and
Yeah,
but
I was actually talking with when I was in Monterey for that.
Oh,
one
good.
With Katie.
Okay,
She's
fantastic.
a parent, and then I saw her recent presentation that she did for her lumbar spine patient.
It's impressive.
Yeah.
Super duper. Yeah, so imagine that, but in a much more formal, you know, setting with, you know, hey, what did you learn from last week's reading about, you know, the SI joint cluster, about the lumbar spine exam, about the presentation of hip pathology, etc. And then this is how we put it together in an exam room. So that's for our orthopedic residents. But questions?
No, that was pretty thorough.
Okay, there's a lot.
Yeah, but your explanations were really clear and concise.
Okay, perfect. Good?
Yep.
Okay,
Good.
fantastic. Thank you for
Thanks,
spending so much time. Yeah, absolutely. You got it.